Good afternoon, everybody. It's Dr. Tom Pitts reporting here with Trial Site News. I'm coming back excited for this week's show where I'll be answering some of the questions from the comments left from my last show, which featured myasthenia gravis, an autoimmune neuromuscular disease. It happens to be my life's work and passion, actually, as a neuromuscular or autoimmune-based neurologist. So today I'll answer the questions regarding myasthenia gravis, and then I'll move on to another topic that Trial Site has highlighted and done extensive coverage on recently, multiple sclerosis. I'm proud to say that I'm a board-certified neurologist and board-certified clinical neurophysiologist from the American Academy of Neurology. I am also I have added qualifications in headache medicine from the National Headache Foundation. I'm a Myasthenia Gravis Foundation of America partner provider, and I'm currently their doctor in residence at their monthly MGFA support group for the patients here in New York City. And lastly, and most relevant for today's show, I'm also a certified multiple sclerosis clinical specialist from the Multiple Sclerosis Consortium of Specialists. So without further ado, let's jump right in. So last week, or on last week's show, I talked about myasthenia gravis. And I had some very interesting questions. So let's start with some easy ones. Well, someone asked me, does a rheumatologist usually treat this? There's a lot of overlay between an autoimmune neurologist or someone dealing with autoimmune hematologic oncologic problems. We're all basically masters of immunomodulating you within confines of our certain diseases. Now, where things differ are the diagnostics, the clinical exam, right? Do you want, your neurologist doing your hem-onc exam? Do I know how to look at your lymphocyte lines and things like that, like your hematologist? No. On the other hand, does your oncologist perform electrodiagnostic studies of the peripheral nerves like I do? No. Do they do, maybe as good a detailed neuro exam as a neurologist? I'd hope not. So that's why we have individual specialties. So rheumatologists do not traditionally treat myasthenia gravis, as it is a neuromuscular disease. It affects the neuromuscular junction of the nervous system. So that falls within the confines of a neurologist. Now, rheumatologists and neurologists often collaborate intimately because myasthenia gravis often coexists, as I mentioned, with other autoimmune diseases. And they may be rheumatologic diseases like Sjogren's or lupus. And we work collaboratively, and in a way, they do become a treater of myasthenia, and I would indirectly become a treater of the rheumatologic disease because we are collaborating to immunosuppress you as effectively as possible, meaning we're trying to really line up the antibodies you have, what they're expressing, what part of the immune system they're enticing, and then we try to line up a med that inhibits the minimal necessary amount of the immune system or immune activity to put you into remission, but still give you a solid immune defense, host defense against everyday pathogens in a big city like New York City. Another question was, does this have to do with chronic fatigue syndrome? No, not directly, it does not. A blockade of the neuromuscular junction is not pathognomonic with chronic fatigue syndrome. However, you can see other autoimmune diseases. Like I said, there are other problems that can live with myasthenia gravis. Myasthenia gravis patients can have fatigue, muscle fatigue, and energy fatigue. There can be superimposed secondary and tertiary symptoms, so like depression, thyroid dysfunction. So chronic fatigue, I always want to know, is there something else going on? Just like I want to know with myasthenia, and maybe they just called you chronic fatigue, but really you have some hypothyroid problem or something like that. If you have true chronic fatigue syndrome, I'm talking at the mice model or pathophysiology level, no, they are not the same disease. That being said, I'll bet there are patients that suffer from both. And if that's the case, they might be a nice resource to reach out to through some of the chronic fatigue patient support organizations that are available nation and worldwide. So now let's segue into multiple sclerosis. So multiple sclerosis is one of my other passions because, again, it's an autoimmune neurologic disease, this time affecting the central nervous system. So we're talking about the brain, the spine, and the optic nerve, meaning the nerve that conveys information incoming from the eye, the retina, all those structures back through the brain into the visual cortex, which is located in the back of the brain in the occipital lobe. So we're talking the most valuable, arguably, real estate in the body here affected. So it is an autoimmune disease, meaning autoreactive lymphocytes or T cells usually penetrate the blood-to-brain barrier, so you have kind of a bouncer. Not all medications or substances introduced to the body have the ability to interact with the central nervous system, and that is a very smart thing, right? We don't want to just have unlimited access into kind of our heart, our brain or cortex, right? So unfortunately, these autoreactive T cells do penetrate the blood-to-brain barrier, and they attack something called the myelin sheath, or the coating of the nerve, meaning the insulation. Picture copper wire, right? We're not talking about the axon or the wire itself. We're talking about the myelin sheath, or the insulation around it, which allows for prompt or rapid conduction of nerve propagation. So when you want to do something like move, that should happen very quickly, right? And that's because you have solid nerve propagation from the cortex descending down through the various neuroaxis pathways all the way to the muscle, and you're able to complete that task. However, in multiple sclerosis, and there are a few types we'll talk about, what we see is an autoimmune attack that are inflammatory based, targeted against the myelin sheath of the nerves in the central nervous system, and what they're called demyelinating. So they actually will wear away or attack or take away the coat around the nerve axon, and you do not have prompt propagation, causing sensory motor deficits, so numbness, tingling, burning, things like that, usually with a power deficit, a true strength deficit. So we're not talking necessarily about fatigue, although that is a secondary symptom of multiple sclerosis. We're talking about a true power or strength deficit. There are things like optic neuritis, meaning a unilateral or one-sided attack of an optic nerve, right? It's very rare from a multiple sclerosis patient to get simultaneous binocular, both eyes, optic neuritis. That is much more commonly seen in something called neuromyelitis optica, formerly known as Devick's disease, of which we now know there is a spectrum, which we refer to as the neuromyelitis optic spectrum disorders. This used to be kind of grouped in inappropriately with MS, and we know that certain MS medicines can worsen NMO. So we know that these are two distinct entities. Going back to MS, optic neuritis is usually characterized by an attack of one optic nerve, and something like 80% or just around 80% will have vision problems in their life. However, they can have recurrent attacks of the same optic nerve, or later suffer an attack of the contralateral or opposite eye. The spinal cord affects movement of the arms and legs, cervical spine, the top part affecting the arms, lumbosacral spine affecting the legs. The thoracic spine in the middle can cause something called the sensory level, right? So the sensation between kind of your neck and your lower back area. You can have bladder dysfunction because a lot of those autonomic pathways, things we don't think about, are under the control of the autonomic nervous system, like bladder, breathing, heart rate, sexual function, defecation. All these things we don't think about happen kind of magically in the background, but actually there's a very coordinated orchestra that has to happen, neurologically speaking, through the autonomic nervous system, which is disrupted with attacks, usually of the cervical spinal cord. And it will lead people oftentimes with bladder dysfunction of various types. Urge incontinence, where you suddenly have to go and there's no buffer zone. You just have to go right there. Frequency, where you have to go quickly. Atonic bladder, where the bladder doesn't move and we have to use self-catheterization to liberate urine from an otherwise paralyzed bladder. It may necessitate the use of bladder stimulators. It can cause spasticity, right? So spasticity or tightening of a muscle, meaning a weak muscle will just fall or be totally incapacitated a lot of times in MS. But with spasticity or tightening of the muscle, it allows you to kind of prop up your hand in a very tight form so that there may be some function or support. However, that can be very painful for patients, and agents like or neuromuscular chemodenervation agents such as Botox or MyoBlock or Dysport. So multiple sclerosis, as you can see, by affecting the central nervous system, essentially has the ability to affect almost every system in the body. Now, thankfully, we have made a few strong advances in this area that have changed the game entirely for the way us neurologists deliver care, and it creates a more bright future for our patients. I'll explain. So first of all, we have really organized our diagnostic criteria. We have the Mcdonald Criteria, the revised Mcdonald Criteria, that really spells out how you should be diagnosing multiple sclerosis. And, anytime you have a diagnostic criteria that is validated and accepted and implemented successfully, it really leads to success. Because I think as a society, we've come into a treatment kind of excited group here. Like where whenever I'm at a restaurant, I'll hear somebody say back pain, and somebody immediately is like, try this, this, and this. And my doctor mind kicks in and I say, well, what are you treating? What's the diagnosis? So the diagnosis is always key before starting treatment, because actually then the treatment becomes very clear and safe, right? Now I have with the diagnosis all these literature resources I can fall back on, treatment guidelines, world consensus guidelines. I can reach out to other colleagues. There's years of validated data on safety, on alternative treatments, on rehab considerations, on lifestyle considerations, on prognosis and outcome. So living in the diagnosis is where the pros are, right? We don't just jump to treatment unless it's an absolute emergency, right? So we have a diagnostic criteria. We have excellent diagnostic modalities. Our MRI scans with and without gadolinium can show us if you fulfill the image criteria in the vast majority of patients, right? We're looking for demyelinating lesions anywhere in the optic nerve, the brain, the cervical spine, thoracic spine, or lumbosacral spine, rarely. And if they enhance, they're active. If not, they tend to be dormant or old. But nonetheless, we can track the lesions. We can re-image you and use your lesion burden kind of as a marker of success or failure of therapy. So annually or every 6 months, we can know whether to titrate or increase or decrease your medicine. There are outstanding rehab programs that have been centered around multiple sclerosis care. We have medicines that assist with walking speed. We have medicines that assist, as I mentioned, with spasticity. And so we've come a long way. The lumbar puncture or the spinal tap showing oligoclonal bands, oftentimes with the great diagnostic criteria, is not necessary anymore. It can be sometimes for more equivocal cases, but the vast majority of people don't need it anymore, which is fantastic. So moving on to probably the most important part, our treatment landscape has exploded, right? I mean, just rewind back to maybe our parents or their parents' generation, and we were talking about interferon. That was it. Then there was Plegridy, this long-lasting, interferon, and that was the next best thing. Then we had Copaxone, and we have, oral medicines like Aubagio and Tecfidera and Gilenya. Now, however, we've seen an explosion. I mean, it just felt like as a neurologist, we had this steady increase in medicines, and now the landscape has exploded, and we're seeing different indications showing a progression of our knowledge, right? Certain ones are for relapsing, remitting multiple sclerosis, which is the most common form, where you have distinct attacks and then disability, which slowly improves over time, usually not all the way to baseline. And then you have periods of remission or attack-free periods followed by other relapses, which then remit again. There's a secondary progressive course, which many relapsing remitting patients will eventually kind of convert into over time, where you actually do have steady neurologic decline in between acute attacks. And then finally, there is the primary progressive form. Now, the relapsing remitting form and the secondary progressive show a female predominance, almost twice as many females as men, and it's typically 20 to 40 years of age, like most autoimmune diseases. That being said, the primary progressive form, which is characterized by progressive neurologic decline, sometimes with acute attacks on top of it, does not show a gender predominance and tends to happen a little bit later in life. Now, we have medicines that are indicated for each one of these and sometimes multiple forms, which is very promising. We're able to afford our patients the options of doing sometimes only twice annually infusions, as can be seen in ocrelizumab or Ocrevus. We are seeing once monthly subcutaneous injections, ofatumumab. We're seeing oral medicines that are only once daily and seem to be much more tolerable than some of the older injectable, per patient accounts and things like that. And we're increasing this safety. I like the fact that they're all going through the FDA regulatory pathway. We're getting solid evidence that is, looked at, carefully scrutinized through the various phases, gaining an official approval for a very evidence-based indication, no more just MS, right? It's relapsing remitting MS, secondary progressive multiple sclerosis, and that should show you how targeted we're getting with these things. Some of these medicines are decreasing lesion burden on the MRI. Many of them have halted a lesion burden or accumulation in many. And that allows you to have more meaningful rehab and gains, right? Because you can do rehab for a year, you can really make some solid gains, you have another attack, and you end up in this kind of net loss where you're taking one step forward every year and 2 steps back. And what we want to do is give you as long a relapse free period as possible, not just so you don't have acute attacks and more disability, but so you have the time to make up the disability to the largest extent possible, usually under the guidance at MS centers around the country, under the care of MS specialized rehab teams. So I'm just so proud to be a part of this fight because it's grown so much and we're able to really change the game for people. I want to mention something else very interesting about multiple sclerosis. Let's talk about vitamin D. Vitamin D. I love vitamin D. And you might say, vitamin D, what about vitamin D? Well, I got to tell you, I don't love all vitamins, guys. We've gone a little bit crazy with the supplementation, in my opinion. I'm seeing high vitamin B6 related sensory neuropathies, which are irreversible. Magnesium can worsen myasthenia gravis. I'm not saying, that there's not a role for this. Of course there is. It needs to be under the guidance of a healthcare professional. We're not getting it from the GMC guy, not to knock GMC, right? But has to be. These are all medications. If you think of the true naturopath definition, right? Like, is it natural to cave people go around just like putting prepackaged vitamin in high concentration into their body? That's not natural. But what we do promote for MS patients, there are a few that have evidence behind them. We want evidence behind them. Once you show us something is safe and tolerable in a formal study, we can tell real people, real moms and dads, to put this in their body because we have safety data. So now let's get into vitamin D and biotin. Vitamin D deficiency is a massive part of autoimmunity. It is a risk factor for multiple sclerosis, which is why you see a longitudinal predominance as you go further from the equator. You see an increase in prevalence and incidence of multiple sclerosis. And usually these patients have a low vitamin D level. We've also found vitamin D in studies to be disease modifying. It's not really a supplement, it is a treatment for MS. And we think that this may have a larger role in autoimmunity. In some of these rare diseases like myasthenia gravis, there's not a formal vitamin D trial, but you wonder, it's certainly thought-provoking. It probably would work. I'm not aware of vitamin D causing worsening of myasthenia gravis, but we don't have that large data because it's a relatively rare disease like MS. But MS has done this study, and it's wonderful that we have kind of a natural therapy that is actually disease-modifying with safety and efficacy data behind it. Biotin is another one. You can see this on the MS Society website, some of their dietary considerations. They go over things like the different diets, the wall paleo diet, the Mediterranean diets, vegetarian. And there's some wonderful interactive videos on the MS Society website that you can check out. Vitamin D is a fantastic example of what happens when we take a natural therapy and we do proper studies and back it by evidence. It's readily adoptable. Doctors are ready to use these things. We just need the data so we can tell you it's safe and that we know it works and to what extent and what dose. So this is vital. Knowing that we have this much data between the diagnoses, the treatment, the exploding treatment landscape. I'm excited with all these trials continuously ongoing in the MS world. The rehab advances, the fact that we're moving towards this naturopathic interplay that has solid evidence done by, solid professionals at, non-financially, monetarily incentivized institutions. It's huge for MS patients. It has changed the game. It has changed the cost of care, right? We used to have bedbound patients with debility, and it was just horrible for everyone. The patients had no quality of life. Things got worse and worse. And we're really switching the game. We're seeing MS patients run marathons. We're seeing them have marriages and wonderful, enjoyable experiences in life, playing sports, doing anything anybody else wants to do. And I should mention, pregnancy has been considered a kind of a safe period for MS. Now, that's interesting, right? Maybe relative immune suppression as you kind of dim down your immune response to not reject the placenta as a mom, but it has been safe. So, we want patients having kids if they want to. We want patients playing sports if they want to. That's the goal. Get you moving. I'm proud to talk about multiple sclerosis, not only as someone who has a family member with multiple sclerosis, but also as a neurologist who is subspecialty certified in multiple sclerosis care. I'm extremely proud to be on your team. I'm extremely proud to report on behalf of Trial Site News that we will be following the exploding MS treatment landscape. and I'm excited to hear some of the questions that you may have, and I'll answer them like I did this week in next week's show. So I'm Dr. Tom Pitts. I'm reporting here from New York City, the Big Apple. I want to wish everybody a wonderful weekend. To all of those struggling with any disease, but especially here on this episode, multiple sclerosis, you're not alone. And there's a lot of people that wake up. We're not coming out to lose for you. The fight continues, and we're going to be keeping up with it here on Trial Site News as it happens. Take care.